Major update for older adults. New elder care bill approved. What changes right away? Picture waking up tomorrow and learning that the government has quietly changed the rules around how your parents, or maybe even you, receive care, medical help, and financial support in later years. Not a rumor, not a proposal. Finished, signed, and real. And most people have absolutely no idea it happened. That is exactly what we are looking at today. And I promise you, by the time we are finished here, you will know more about this than most people who work in healthcare policy, because this affects tens of millions of Americans. And the news cycle covered it for about 48 hours before moving on to the next story. But the impact of this bill? It is going to be felt for decades. Stay with me because this one matters. Let us begin with something that does not get discussed enough.
Right now, there are over 57 million Americans who are 65 or older. By 2030, which is closer than it seems, that number is going to be close to 73 million. 1 out of every 5 people in this country will be a senior citizen. And for years, the systems built to support those people, Medicare, Medicaid, assisted living rules, and home care access, have been straining under the weight of that reality. Families have been doing the math, and the math has not been working. The average cost of a private room in a nursing home in the United States right now is somewhere around $105,000 a year. Assisted living facilities average around $54,000 annually. And home health aides, which most seniors prefer because it lets them remain in their own homes, can cost anywhere from $25 to $40 an hour. If your parent needs care 5 days a week, 8 hours a day, you are looking at $52,000 to $83,000 a year just for that. And Medicare. Medicare, which most seniors rely on as their main insurance, has historically covered very little of that. It covers short-term skilled nursing after a hospital stay. It covers some home health visits if you meet specific criteria. But long-term custodial care, the kind most older adults actually need, was mostly left to Medicaid, which requires you to spend down nearly all of your assets before you qualify, or to private long-term care insurance, which most people either cannot afford or never thought to buy when they were younger. This has created a quiet crisis. Families across America have been stuck in the middle. Adult children, mostly women statistically, have been leaving jobs, cutting hours, draining savings, and burning themselves out trying to care for aging parents because they simply could not afford to do it any other way. That is the world this bill is stepping into. And whether it fixes everything, it does not. And I will be honest with you about that. It does change some things in ways that are going to be felt immediately and meaningfully by real people. Let us talk about what is actually in it. The first and probably most immediate change has to do with in-home care access under Medicare. This has been one of the most frustrating gaps in the system for years, and the new legislation directly tackles it. Previously, to qualify for home health benefits under Medicare, a patient had to be certified as homebound. That sounds simple, but in practice, it was applied incredibly strictly. If you were a senior who could walk to your mailbox, go to a doctor appointment, occasionally attend a church service or family gathering, even if doing so required major effort and left you exhausted for the rest of the day, you could be denied home health coverage on the grounds that you were not truly homebound. That standard has now been revised. The new language in the bill defines eligibility based on functional need rather than physical confinement. What this means in plain English is that seniors who have documented functional limitations, difficulty bathing, dressing, preparing meals, managing medications, or moving safely around the home, can now qualify for home health services without having to prove they are basically unable to leave the house. For families who have been fighting insurance denials, appealing Medicare decisions, or paying out of pocket for care their loved ones genuinely needed, but could not technically qualify for under the old rules, this is a significant shift. And because it changes the eligibility criteria at the federal level, it applies to every state, every Medicare plan, effective with the bill's implementation date. The second change is about caregiver support. And this one hits differently because it is not just about the seniors themselves, it is about the people taking care of them. There are approximately 53 million unpaid family caregivers in the United States right now. These are spouses, adult children, siblings, sometimes even grandchildren who are providing care without any compensation, without any formal training, and without any real systemic support. The economic value of the work they do, if you were to calculate it based on professional home care rates, is estimated at over $470 billion a year. These are people who are doing the work of an entire industry for free because they love someone. The new bill creates what it calls a Caregiver Support and Relief Program. This is a federally funded initiative that does a few specific things. It establishes access to respite care, meaning temporary relief care, that allows family caregivers to take breaks. If you have been caring for a parent with dementia 7 days a week and you have not had a day off in months, the federal government is now setting aside funding to provide short-term substitute care so you can rest, recover, and avoid the full physical and emotional collapse that caregiver burnout can cause. It also creates a caregiver training program, funded through grants to states that provides free or subsidized training for family members on things like safe patient transfers, wound care, medication management, and how to recognize the warning signs of medical decline. This is genuinely practical. A lot of people are caring for family members without any idea how to do it safely for themselves or for the person they are caring for. And perhaps most importantly for some families, it establishes a pilot program in 10 states with plans to expand nationally based on results that allows family caregivers to receive a modest stipend for the care they provide. This is not a large amount of money. Let us be clear about that. The early numbers being discussed are in the range of $1,500 to $2,000 a month for caregivers who meet certain criteria and provide a certain number of hours of care per week. It is not a salary, but for a daughter who cut her hours at work to care for her mother, it is something. It is the government acknowledging, for the first time in a meaningful, funded way, that this labor has value. The third major change involves nursing home and assisted living facility standards. And this is where the bill gets into territory that will matter enormously to families who are either already navigating the long-term care system or who fear they will have to in the coming years. The pandemic exposed something ugly about the nursing home industry in this country. Facilities that were understaffed, underfunded, and underregulated became epicenters of death. Nearly a third of all COVID deaths in the United States in 2020 were tied to long-term care facilities. And even before the pandemic, reports of neglect, abuse, inadequate staffing, and poor conditions had been piling up for years. The new bill addresses this in several concrete ways. Staffing minimums are now federally mandated for nursing homes that receive Medicare and Medicaid funding, which is the vast majority of them. The specific requirements include a minimum number of registered nurse hours per resident per day, a minimum number of certified nursing aid hours, and a requirement for at least one registered nurse on site 24 hours a day, 7 days a week, which many smaller facilities were not meeting. Now, it is important to be honest here. Nursing home industry groups have already pushed back hard on these requirements. They argue, and there is some legitimate truth to this, that there is a workforce shortage in direct care, that finding enough qualified staff to meet these minimums will be difficult in rural areas especially, and that the cost of compliance could lead some facilities to close. These are real concerns, and they are not being ignored by the people who wrote the bill. There are transition timelines built in, with the most demanding requirements phased in over several years, and there are financial support provisions included to help facilities with the cost of hiring and training. But the baseline principle that a minimum standard of care must exist, and that it must be enforced, and that residents and their families have the right to know whether a facility is meeting it, that is now written into federal law. In addition, the bill creates a national public reporting database within 18 months of passage. Every nursing home and assisted living facility that receives federal funding must report staffing levels, health inspection results, quality measures, and resident and family complaint data to a centralized public database. This information will be available to anyone. You will be able to look up a facility before you choose it, or while your loved one is living there and see its actual record, not the marketing brochure version. The fourth area the bill addresses is prescription drug costs for seniors. And while some of what is here was already set in motion by earlier legislation, the new bill expands and speeds up several of those provisions. The $2,000 annual out-of-pocket cap on prescription drugs for Medicare Part D beneficiaries, which was established under the Inflation Reduction Act, is now paired with an additional provision that smooths out the payment of that cap across the year. Rather than requiring some seniors to hit a massive cost wall early in the year and then wait for it to reset, this payment smoothing option is now automatic for all Part D enrollees unless they opt out, which is a change from the previous version where it was opt-in. That sounds like a minor technical detail, but for seniors on fixed incomes who were getting hit with large drug bills in January and February, it is a meaningful cash flow change. The bill also expands the low-income subsidy program known as Extra Help, which helps seniors with limited income and resources pay their Medicare Part D costs. The income eligibility threshold for full Extra Help benefits has been raised, which means an estimated 1.2 to 1.5 million additional seniors will now qualify for substantial premium and cost-sharing reductions on their prescription drugs, who previously fell just outside the eligibility line. And the insulin price cap for Medicare beneficiaries, which was set at $35 a month, is now extended to include all insulin types, a fix to an earlier provision that had applied only to certain formulations and left some diabetic seniors still paying more than the cap. The fifth piece of the bill deals with something that rarely gets headlines but affects an enormous number of people: the Medicaid asset limits for long-term care. Here's the situation that has tormented middle-class families for decades. Medicaid will pay for nursing home care, but only if the person receiving care is essentially broke. The program has asset limits, and to qualify, a senior generally has to spend down their savings to a very low threshold before Medicaid will kick in. In most states, the individual asset limit for a single person is around $2,000. $2,000. After a lifetime of work, after saving, after trying to be responsible, you have to reduce yourself to near total financial poverty before the government will help you pay for the care that is keeping you alive. The spend-down requirement has also caused enormous harm to married couples. When one spouse needs nursing home care and the other is still living at home, what is called the community spouse, the rules around how much the at-home spouse can keep have been complicated, inconsistent across states, and in many cases, deeply inadequate. The new bill does not eliminate the Medicaid spend-down requirement. Let us be clear about that because it is important not to overstate what is happening here. But it does make two significant changes. First, it raises the asset limit threshold for Medicaid long-term care eligibility to account for inflation, and it sets a federal floor, meaning states cannot set their limits below this new baseline, though they can go higher. This is not a transformation of the system, but it does mean that a senior will not have to spend their last few thousand before help arrives. Second, it expands the protections for community spouses, the husband or wife still living at home. The amount of assets and income that a community spouse is allowed to keep while their partner receives Medicaid-funded nursing home care has been adjusted upward in a way that in practical terms means fewer at-home spouses will be forced into poverty to qualify their partner for care. Now let us talk about something the bill does that is newer and less understood, but potentially very significant over the long term. Its investment in home and community-based services, usually abbreviated HCBS. Home and community-based services is the umbrella term for the kinds of support that allow seniors and people with disabilities to live in their own homes or in community settings rather than in institutions. This includes things like personal care aides, homemaker services, adult day programs, meal delivery, transportation to medical appointments, assistive technology, and home modifications like grab bars and ramps. Medicaid already covers these services for some people through what are called waiver programs. But access to these programs has historically been deeply inadequate. In most states, there are waiting lists, sometimes thousands of people long, sometimes with wait times measured in years. For Medicaid waiver slots for home and community-based services, people have literally died on waiting lists while waiting for care. The new bill allocates $35 billion over 10 years specifically for expanding home and community-based service capacity. States will receive enhanced federal matching funds, meaning the federal government will pay a higher percentage of the cost if they expand their HCBS waiver programs, reduce waiting lists, and improve the wages and working conditions of direct care workers. That last piece matters enormously. The reason there is a direct care worker shortage in this country, the reason families cannot find home health aides even when they can afford to pay for them, is that these jobs pay poverty wages. The median pay for a home health aide in the United States is somewhere around $14 to $15 an hour. It is physically demanding, emotionally heavy work with no benefits, no predictable hours, and no career ladder. The enhanced federal matching funds in this bill are specifically conditioned on states showing that a meaningful portion of the increased funding is going directly to wage increases for direct care workers. It is an attempt to attack the workforce shortage at its root. There are also several provisions in the bill that deal specifically with dementia care, which deserves its own attention because dementia is in many ways the defining challenge of elder care in our time. There are currently about 6.7 million Americans living with Alzheimer's disease. By 2050, that number is projected to reach nearly 13 million. The cost of care for people with dementia is staggering, averaging well over $350,000 over the course of the illness, and the burden on family caregivers is unlike almost anything else in the healthcare system. Caring for someone with advanced dementia is a full-time job that does not end on weekends, does not take holidays, and gets harder every single month. The bill establishes a national dementia care coordination program that funds specialized care navigators, professionals who help families understand what services are available, how to access them, how to plan financially, how to connect with support groups and respite resources, and how to navigate the transition points in the illness when care needs change dramatically. This is the kind of person that families who can afford a geriatric care manager have been able to hire for years. This program makes that resource available at no cost to Medicaid-eligible individuals and at reduced or no cost to others through community-based organizations and area agencies on aging. The bill also increases funding for dementia-specific training for direct care workers, nursing home staff, and emergency responders because one of the documented dangers for people with dementia is what happens when they encounter a healthcare or emergency system that does not understand how to interact with them safely and compassionately. Now, I want to take a moment and talk honestly about what this bill does not do, because I think you deserve that. It does not create universal long-term care insurance. There was a proposal in earlier versions of this legislation, versions that did not make it through, to establish a federal long-term care benefit similar to what some other countries have. That would have been transformative. It did not survive the political process. What we have instead is an improvement to the existing patchwork system, not a brand new foundation. It does not fully solve the direct care workforce crisis. The wage provisions and the enhanced federal matching are a step, but $14 or $15 an hour becoming $17 or $18 an hour, which is roughly the range being projected in states that receive the enhanced matching and comply with the wage conditions, is still not enough to make these jobs competitive with retail or food service or other alternatives. The shortage will not be resolved by this bill alone. It does not eliminate the Medicaid spend down. Families will still face the brutal reality of asset depletion before long-term Medicaid kicks in. The changes to asset limits and community spouse protections are meaningful, but they are adjustments, not structural reforms, and it does not guarantee that implementation will go smoothly. Legislation is passed at the federal level, but so much of elder care is administered at the state level, and states vary enormously in their capacity and their political will to implement these kinds of programs effectively. The same bill can produce dramatically different outcomes in a well-resourced, well-run state versus one that is struggling with its Medicaid infrastructure or that has a governor who is politically opposed to the underlying goals. I am telling you this not to be cynical, but because I think the most useful thing I can do for you is help you understand what is real and what is not, so that you can make actual decisions for your actual family. So, what do you do with all of this? What does it mean for you right now, today? If you have a parent who is currently receiving home health services through Medicare and has been denied for services you believe they actually need, it is worth having a conversation with their doctor and potentially with a patient advocate about what the new eligibility criteria means for their case. The old denial may not apply under the new standard. If you are a family caregiver, if you are the person who is doing the work of caring for an older relative, Find out what caregiver support resources are available in your state through your local area agency on aging. These agencies exist in every part of the country, and they are the entry point to many of the services and support programs this bill is funding. Go to eldercare.acl.gov and put in your zip code. It is a real website, it is free, and it will connect you to local resources. If you have a family member in a nursing home or assisted living facility, you can start asking the facility directly about their staffing levels, their inspection history, and how they are preparing to meet the new federal standards. You have the right to this information, and once the national reporting database is live, which will happen within 18 months of the bill's passage, you will have an independent source to check their answers against. If you are concerned about long-term care planning for yourself or a family member, and you have not worked through the financial picture, now is a time to consult with an elder law attorney or a financial planner who specializes in elder care. The Medicaid rules are changing. The asset limits are changing, and if you have been operating on assumptions about what your family would or would not qualify for, those assumptions may need to be updated. And if you have a parent or a family member who might benefit from expanded home and community-based services through Medicaid, particularly if they are on a waiting list, it is worth contacting your state's Medicaid office or your local area agency on aging to ask about timeline changes, because the enhanced federal funding is intended to speed up the expansion of these programs. I want to close with something that I think often gets lost in the policy conversation. The people this bill is about, the seniors, the older adults navigating a healthcare system that has never been fully built to meet their needs, they are not abstractions. They are people who worked for decades, who raised families, who built communities, who paid taxes, who lived full and complicated and meaningful lives. They are people who are now, often through no fault of their own, and often very suddenly, dependent on systems and people in ways they never imagined. And the people caring for them, the family members, the home health aides earning barely above minimum wage, the nursing home staff showing up for every shift even during a pandemic, those people are doing some of the most important work in our society with almost none of the recognition or support that the work deserves. This bill is not a solution. It is a step. It is an acknowledgement that the status quo has been failing too many people for too long, and that the federal government has a role in changing that. Whether that step leads somewhere depends on how it is implemented, how it is funded over time, how states respond, and whether we as a society continue to hold our elected officials accountable for making elder care a priority. What you can do, the most concrete thing you can do, is know your rights. Know what resources exist, ask questions, and advocate for your family. Information is the difference between getting the care you are entitled to and not getting it. That is what today was about. If this was useful to you, share it with someone who needs it. A friend who is caring for a parent, a sibling trying to navigate nursing home options, a neighbor who does not know where to begin. The people who most need this information are often the ones least likely to find it on their own. Take care of yourselves and take care of the people you love.